Hello student. So we will be discussing the MCQ. As you know ki in physiology test, so we are starting directly with the first MCQs. Okay. So first MCQs here, a 52-year-old may complain of visual disturbance and difficulty in walking. So you know this thing. The diagnosis is given multiple sclerosis. So that occurred due to demyelination of the neuron. So we all know. So multiple sclerosis means it's an demyelinating disease of the central nervous system, and we all know central nervous system means the cells which is responsible for myelination is oligodendrocyte. I believe not much discussion is needed, but here you have to remember that whenever there is demyelination, the most common problem that happens in the neuron is the decrease in the conduction velocity of action potential. So this is also given as separate MCQ. So try to remember that. And why the oligodendrocyte is destroyed? Because you know antibody destroy the oligodendrocyte. So oligodendrocyte means which is forming myelination. Myelination means two important protein name which you have to remember, because the antibody are mainly directed against those proteins. So one is the myelin basic glycoprotein, okay, MBP, myelin basic protein, MBP, generally MBP, myelin basic protein, and second one is the MOG, myelin oligodendrocyte glycoprotein. So the basically antibody is directly directed against these two protein, and that is the source of the antigen for this kind of antibody production. So try to remember this extra information. Next question, match the following neurotransmitter. So whenever you are getting this kind of question, match the following, try to match which you already know, the thing which you know. Just say if you give me the same question, so first of all I will try to match this acetylcholine with nucleus basalis or Maynard, because I know that. Okay, then dopamine also, I believe all of you know that dopamine is substantia nigra. So after these two matching, try to check that A is with 2, so A is 2, so answer already done. So A2 means obviously the answer is going to be C, because there is no such match where A is 2. So even if you know only one thing, that answer is done. Even if you know at least this dopamine substantia nigra, then also you can exclude C4, either your B or C will be the answer. So go in this fashion, right? So first you connect whatever you know, uske baad you know serotonin means raphe nucleus of the magnus, and the norepinephrine means locus coeruleus. So if you connect all of them, so easily your answer will be done. Okay, very good. Our next question, a patient presented with a loss of pain and temperature sensation on left side of the body below the spinal cord lesion. Upon examination, sensation impaired crude touch also, and each on the same side but fine touch. So fine touch and proprioceptions are intact. Fine touch and proprioception, they are the sensation of the dorsal column or posterior column. So they are the sensation of dorsal column. So dorsal column is basically intact in this question, but we all know that this pain and temperature, they are carried by the lateral spinothalamic tract. So lateral is also gone, plus crude touch and itching and sexual sensation, they are carried by the anterior. So anterolateral spinothalamic pathway is basically damaged. So answer is option number B. You are absolutely correct. Okay. Next question, match each of the sleep disorders. So this is one thing which I generally forget, because this is a kind of thing which you have to memorize in your brain. But I always remember bruxism is stage 2. So I always remember bruxism is stage 2. So if I remember this, try to see that how much thing is your done. So B is equal to 1. So B equal to 1 means either B or D will be the answer. Now try to remember at least one thing. So somnambulism is basically the which is the answer? Somnambulism is basically the stage 3 and 4. So if you just connect these two, somnambulism, then also your answer is done. But see, there is one confusion here. One is narcolepsy, which is REM sleep disorder, and sleep paralysis. So REM has been given here also, here also. So better to avoid this C and D matching first. Okay, first of all you try to match A and B. If your answer is done, so somnambulism is stage 3 and 4. So if you just connect these two dot, then remaining is done. So basically your answer is B here. So A is 4, B is 1. So now C is 2 and D with 3. C is 2. So narcolepsy is 2, REM sleep disorder. And sleep paralysis, end of REM sleep. So sleep paralysis is a phenomena which happens during the normal sleep stage, because you know ki REM sleep means that sleep is kind of known as the paradoxical sleep. Okay, so this name is important for MCQ, paradoxical sleep. And why it is known as the paradoxical sleep? Because you all know that in REM sleep, if you look at the EEG, so this will looks like a beta like wave, which is a awake person EEG wave. So this beta like wave, but if you look at the muscle tone, so you will see that silent EMG recording is there, silent EMG. So silent EMG means it's a kind of paralysis condition. So there are certain kind of dream in REM sleep where you will not be able to open up your eyes, you will not be able to move your limbs. So because that is a kind of complete paralysis kind of scenario in a dream. So that is known as the basically sleep paralysis that generally happens at the end of the REM sleep. So these are the things that you have to remember. But here I have given you the same thing which I have already taught in my rapid revision as well as the main video, that sleepwalking is the stage 3 and stage 4 disorder. Sleep talking is mainly the stage 1 and stage 2. Bruxism, I told you, I always remember this bruxism at least because it's a stage 2 mainly disorder. Okay, and narcolepsy is very important, and this nightmare that I told you, that vivid dream where the paralysis like scenario is happening. So that vivid dream is also a feature of the REM sleep disorder. So these are the things that you have to remember. Okay. Now next question here, 40-year-old came to the clinic, complaints with burning pain right hand following a chemical spill causing tissue damage. So chemical burn, tissue damage, but tissue damage does not mean the chemical is directly causing pain. Okay, you remember that whenever there is damage to the tissue, okay, tissue damage due to chemical injury, this damaged tissue releases important chemicals like, for example, bradykinin, okay, and prostaglandin. So these are the two main things which are going to released fast from the damaged tissue. So if I look at these two things, bradykinin is the most potent pain producing substances. So the person is feeling pain mainly because of the release of the bradykinin in this answer. So bradykinin is the answer better. Although serotonin is also responsible for causing pain after chemical damage, but serotonin will be released later on. But first there will be release of the bradykinin and prostaglandin. Prostaglandin is a nerve sensitizer and bradykinin is a pain producing substances itself. So better to answer bradykinin in this question rather than serotonin, but D and C both can be answered here. Okay, chalo. Next question, a person moved from his hometown to Delhi. Okay, very good. Respiratory rate 12 breath per minute. After arriving exam center, respiratory rate, so 12 was the normal breathing rate. So 12 was the normal breathing rate. Now whenever he is in anxiety, the breath rate has moved to 20. Okay, now the respiratory center corrected this rate to 16. So after correction, so this 16, okay, it has moved to 16. So still some error is persisting in this system. So if I ask you calculate the gain of this control system, then it will be upon correction upon error hoga. Okay, correction upon error. So how much correction has been done from 20 to 16? How much will be the gain in this question? Calculate. So correction is 20 to 60. So 4 is the correction. Okay, and error is still persisting, that is also 4. So gain is only 1. Almost the gain is nil. But the question here is the regulation factor. So regulation factor I have explained, yes, 100%. So change with regulatory system and change without regulation system. So change with regulatory system means this correction is done and that is with the regulatory system. So regulatory system is there, that's why the heart rate has moved to 16. So change because of this regulatory system is from 12 to 16, only 4 is the change. So 4 is the change with the regulatory system, but if the regulatory system is not there, then how much change will be there? From 12 to 20, that means 12 to 20 is 8 is the change, right? So not 4 upon 4. So change with system, change without system. Okay, so I think your correction upon error, you are saying you are talking about gain, right? So change with regulation is 4 and change without regulation is 8. So here it will be 0.5 is the regulation factor. So these two things are different. One is the regulation factor and one is the gain of the control system. So gain means correction. Correction means how much is the corrected here. Okay, and error means even after correction how much error is persisting from the normal level. So we calculate the gain and we calculate the error. I mean we calculate the correction, we calculate the error. So correction upon error is the gain. But regulatory factor or regulation factor means because of the regulatory system how much correction is happening. Okay, how much error is still there. Okay, so disturbance in the system, after disturbance regulatory factor is trying to correct it. So by definition regulation factor is change with regulation, change with regulatory system presence, and change without regulatory system. If the regulatory system was not there, how much was the change? So from 12 to 18, 20, that is the change if the regulatory system was not there. Okay, but because the regulatory system is there, change is not that much, change is only from 12 to 16. So this is change with regulatory system and this is change without regulatory system. Okay, everybody. So answer of this question will be 0.5. This will be the answer, 0.5. 4 upon 8. So that is 0.5. Okay, this way try to remember this, important. Okay, chalo. Now next thing, which of the following operate based on the negative feedback? So negative feedback mechanism, positive feedback and feed forward control system, important for your MCQ. So thyroid hormone regulation, most of the endocrine control are negative feedback. Blood glucose regulation, so whenever your blood glucose is high, insulin will be released, try to blood. Okay, clotting factor cascade, we all know this is positive feedback. Nerve signal propagation, we also know this is positive feedback because opening of the sodium channel more and more is required for propagation. So these two are the positive. Temperature regulation, in my class I told you this is a negative feedback mechanism as well as a feed forward control system. So 1, 2 and 5 is negative feedback. So answer is option number A. This is the correct answer. Okay, so this way you go about. Okay, I believe you will be able to answer it. Next question, in which part of the neuron are the neurofibrillary tangles primarily found? So this is one of your question which you read in pathology also as well as in medicine also. So in Alzheimer disease, two pathological hallmark is there. One is the neurofibrillary tangles and one is the plaque, right? So here look at, in genome also it has been given. So if you look at this diagram here, so these are the plaque. Okay, so extracellular amyloid plaques, right? So this is the beta amyloid peptides which is deposited outside the neuron. So cell body का outside में dendrites का outside है and axon का outside, दोनों जगह पे amyloid plaque formation is there. Okay, but question is not amyloid plaque, the question is neurofibrillary tangles. So these neurofibrillary tangles are basically intracellular, and where they are mainly deposited, they are mainly deposited within the cell body or soma. So see here, these are the neurofibrillary tangles which are basically hyperphosphorylated tau protein. So these are the main two things that you have to remember, that hyperphosphorylated tau protein are deposited inside the cell body, and because of the deposition, you know, you also have to remember that the axonal transport process which I have read, which I have taught in classes, axonal transport process, this axonal transport process will also be disturbed, hampered. Okay, and that is one of the important pathological mechanism in Alzheimer disease. So neurofibrillary tangle, where it is deposited, your answer is soma, cell body is the answer in this question. Mainly it is deposited in the cell body or soma, and amyloid plaque, they are deposited mainly outside the neuron. Okay, in the interstitial space outside the neuron. Got it? Okay, important one. Okay, next question, pure physiology. The nerve and muscle. So based on the graph showing potassium ion permeability during an action potential, so I believe all of you could able to recall that this red color broken line, so this red color broken line is basically the diagram of your action potential, because depolarization, hyperpolarization सब कुछ मेरे को दिख रहा है. So this is the action potential recording. So along with the action potential recording, so this green color line that you are finding out here, I believe everybody were following. So this green color one, this is the sodium permeability. So first of all, you have to identify which one is the sodium permeability. It is very easy to understand because along with the peak of the action potential, LITI permeability, along with the peak of the action potential, the graph which is also peaking, that is the sodium permeability curve, and this purple or blue color line which is here, this is the potassium permeability. So whenever you have identified the potassium permeability and sodium permeability, it is very easy to answer that maximum potassium permeability at point number D. So point number D means C is going to be my answer. Okay. Okay. Now next question. Question number 10, which of the following event directly result in exposure of myosin binding site on active filament during skeletal muscle? So this question is looking like a similar previous year question. Previous year question was which was required for detachment of the myosin head from actin. So please remember this ATP binding with the myosin head, this is responsible for detachment of myosin from actin. So this is not my answer, this is an previous year MCQ, right? But here question is, which of the following event directly result in exposure of the myosin binding site on actin? So you know ki myosin head is there and actin is there. So there is a portion where the myosin head is supposed to bind, that is known as the myosin binding site. Okay, which event is responsible for opening of that? So please remember that answer of this question will be what? Your answer is D, conformational change in troponin complex, and this will happen in presence of calcium binding with troponin. So whenever calcium binding with troponin, then and then only the tropomyosin will be shifting, and that will leads to exposure of this head. So look at this diagram which is given in Genau. Clearly एक बार देख लो. So this is the myosin head, right? So this myosin head was supposed to bind with this actin subunit. So two actin you are finding out. So this is one actin. I believe you remember that actin means it is composed of multiple small subunit which are known as the G actin. So multiple G actin will combine with one another and it will form a long actin. So this is my actin molecule, another actin molecule, and this individual subunit has a binding site for this myosin head, but normally that binding site is obliterated. That binding site is under the covering of an molecule which is nothing but your tropomyosin. So this thin molecule, filamentous molecule, this is basically tropomyosin. So this is basically tropomyosin, and tropomyosin molecule is known as the gatekeeper molecule. It will prevent the actin myosin interaction in resting condition. But whenever calcium is present in the cytoplasm, see here, this calcium binds with the troponin C. So this is basically my troponin C fragment. This is my troponin C. So look at here, if I take a cross section from this region, what I am finding out, these are my actin subunit, okay. This is the area where myosin head was supposed to bind, but under resting condition this is under the blockage of this tropomyosin. So इसलिए we say that tropomyosin is the hindrance molecules. Tropomyosin is a molecule which is preventing the actin myosin attachment, gatekeeper molecule. But whenever calcium is binding with this troponin C, so this is the troponin C, calcium is bind. Whenever it binds, what happens? There will be conformation change of this whole complex, and whenever the conformation changes, so see here, so this tropomyosin which was located here, it has been shifted in the groove, and whenever this tropomyosin is shifting here in the groove, the other tropomyosin which was covering this actin binding site, this tropomyosin has moved, and because of this movement, now the tropomyosin binding now the myosin binding site has been exposed. So this is the binding site where myosin head was supposed to bind, and this is exposed. So bottom line is that whenever calcium binds with troponin C, calcium binding means there will be certain change in conformation of the troponin tropomyosin complex, because of which this binding site on the actin molecule will be exposed, and who is going to bind here? The myosin head is going to bind here, okay. But after binding of the myosin head, if I ask you which is responsible for detachment of the myosin head, then your answer will be adenosine triphosphate. ठीक है. सो ये दोनों ध्यान रखो कि conformational change of troponin complex is required for actin myosin cross bridge formation, and this actin myosin cross bridge formation is basically done whenever the calcium is present in the cytoplasm. Without calcium, contraction is not possible, okay. So the question can also be given that which of the following is required for cross bridge formation, then also your answer will be conformational change of troponin tropomyosin complex is required for cross bridge formation, and when that conformation is going to change, when the calcium binds with troponin C. ठीक है, that is the thing you have to remember, okay. अब next question चलो, which of the following is not a primary source of mechanism of calcium release in smooth muscle contraction? So we have discussed in smooth muscle, cardiac muscle, skeletal muscle, separate thing. So in case of smooth muscle, what is the source of calcium? Extracellular fluid. So there are certain calcium channel, which are present on the cell membrane, okay. They are the source of the extracellular fluid. So this is important. Sarcoplasmic reticulum, although the sarcoplasmic reticulum is rudimentary, but we all know that there are certain calcium channels present on this which are present on this sarcoplasmic reticulum, that is RYR type 3, okay. So that is present on the sarcoplasmic reticulum. So this is also a source of calcium. And fourth one, calcium induced calcium release. This is also possible because outside calcium which is entering in the cell cytoplasm, that can also stimulate the calcium induced calcium release. So CIC here is also part of the smooth muscle, but this mitochondrial source of calcium is not triggered for contraction. So answer is mitochondrial calcium. Okay, three things you have to remember, that there is a frequent question which is given is electromechanical coupling. Electromechanical coupling for which muscle? For skeletal muscle. Okay, DHPR, ROR coupling we are seeking. Okay, electrochemical coupling. Electrochemical coupling. Chemical coupling. This is the term used for cardiac muscle. And pharmacomechanical coupling. Pharmacomechanical coupling. Okay, this is the term which is used for the smooth muscle. Okay, these are the three terms we have to remember about with different thing. Okay, question बार बार आता है, so please try to remember. Okay, next question, a patient presented with massive blood loss found increased sympathetic nervous system activity. Okay. So whenever there is massive blood loss, we are expecting that the blood pressure of that person is going to fall. So generally we say that baroreceptor, okay, it has an regulatory effect which is from 50 millimeter of mercury up to 200 millimeter of mercury. So this is the working range of baroreceptor. Okay, now chemoreceptor, it will be activated whenever your blood pressure is below 70 millimeter of mercury, and this CNS ischemic response, this CIR, CNS ischemic response will be activated whenever the BP is below 50 millimeter of mercury. So in this patient, because the severe blood loss is there, okay, we are expecting that the blood pressure was fall initially. Okay, here it is showing that the blood pressure is elevated blood pressure, but that is the response because of the sympathetic system activation. But how that response is created? Initially, whenever the blood pressure is below 50 millimeter of mercury, okay, due to severe blood loss, this will causes, okay, so low blood pressure will causes decreased perfusion of the brain, decreased perfusion of brain. Whenever it happens, you know, there will be hypoxia, as well as there will be hypercapnia. So this hypoxia and hypercapnia of the brain is going to affect the respiratory center, obviously it will affect the respiratory center, but here is more important for vasomotor center. Vasomotor center is also known as RVLM, rostroventro-lateral medulla. Now this hypoxia and hypercapnia both are the stimulus for this RVLM, rostroventro-lateral medulla, and whenever this RVLM is activated, this is going to stimulate your sympathetic system. So this is the question basically, that which combination of factor primarily triggered the CNS ischemic response. So CNS ischemic response is triggered whenever the blood pressure is low. Low blood pressure, how it is triggering the CNS ischemic response? Okay, it is producing ischemia of the CNS, that's why CNS ischemic response. But whenever there is ischemia in the CNS, how the sympathetic system is reactivated? That is the CNS ischemic response. It is activated because the hypoxia and hypercapnia is both are the direct stimulus for vasomotor center, and vasomotor center is a kind of sympathetic center. So whenever this vasomotor center or rostroventrolateral medulla is activated by hypoxia and hypercapnia, okay, so what will happen? The sympathetic system will be strongly activated, and that will causes increase in blood pressure, but that increased blood pressure will not stay for long duration. Ultimately, you have to replace the blood, you have to transfuse the blood or transfuse the fluid that are going to help. Okay. So that's why the CNS ischemic response, what is the other name of the CNS ischemic response? The CNS ischemic response, CIR, is also known as last ditch resort. Okay, last ditch resort or last ditch response. So these two things you have to remember. CNS ischemic response is also known as last ditch resort or last ditch response. Okay, good. Okay, now then next question, 55-year-old patient, heart rate control. Okay, so heart rate is slow. So what is the mechanism contribute to slow heart rate? So basically this is related to the pacemaker activity. Okay, so pacemaker activity in my lecture I have discussed. Okay, this is a session for INI-CET. Okay, so this is the normal SI nodal action potential. So normal SI nodal action potential, there is a phase which is known as the prepotential. Okay, and prepotential, whenever the slope of the prepotential decreases, okay, that is going to produce the decreased heart rate. Okay, so the slope of the prepotential, whenever it is decreases, that is going to decrease the heart rate. Now if you could recall what is the ionic basis of this prepotential, then I told you this is sodium current followed by calcium current. Sodium current is through the HCN channel, which is also known as the funny current, So if this funny current is decreased or inhibited due to any reason, then what will happen? The slope of this prepotential will also reduce, and whenever the slope of this prepotential is reduced, then the next action potential is going to appear a little later. Little later means what will happen to the heart rate? The heart rate is going to fall. So in this question the best answer is the decrease in the funny current. So decrease in the funny current is due to if there is this, so what will happen? There will be decrease in slope of prepotential, and whenever there is decrease in slope of the prepotential, then what is going to happen? The heart rate is going to reduce. So that is the mechanism which is going to happen here. Baki, you can easily exclude that if you stimulate the activity of the L-type calcium channel, it will causes increase in heart rate. Enhance sympathetic stimulation, it will also increases heart rate. Okay, activation of T-type calcium channel, it will also increases the slope of the prepotential and heart rate will increase. Yes. So basically the drug that has been given here, ivabradine, very good, because this funny current channel blocker, the drug we have known ivabradine. Okay. So this is the answer. Beta blocker you can also give. Beta blocker is not acting directly on the funny current, but they can also decrease the slope of the prepotential. Okay, I will tell you, there is another question here. Okay, so now the question number 14, next question. Which of the following best describe the effect of the cyclic adenosine monophosphate? So here the prepotential which we are discussing, this prepotential which we were discussing in the previous one. So there is a little detailed version of this prepotential. So this prepotential is done by, I told you that HCN channel as well as the calcium current here. So what type of calcium current? T-type calcium channel, and then the phase 0 or depolarization phase, all of you know. So this is also due to calcium, but here the L-type calcium channel is there. Okay. Now if you stimulate sympathetic system, it causes generation of the increased CAMP inside the nodal cell. Okay, inside the nodal cell, and whenever the CMP increases, the CMP has stimulatory effect, okay, on this HCN channel, as well as it has also stimulatory effect on this L-type calcium channel. I believe you remember this. Okay, so whenever you stimulate this thing, okay, whenever the sympathetic system is stimulating this thing, so you can easily understand that what will happen to this prepotential slope. It will be rapid, faster, steeper, and then action potential will appear earlier than previous action potential. This will causes increase in heart rate. So this is the actual understanding which you should be there, and that's why if you block this sympathetic activation by beta blocker, then heart rate will decrease. That is the opposite thing. Okay, so here the question is which of the following best describe the effect of CAMP on heart? So what the CAMP is doing? CAMP is decreases the heart rate. So whenever this is decreases the heart rate, so this is false. CMP increases the heart rate, correct, by enhancing opening of the L-type calcium channel, also correct, also enhancing funny current. So this is absolutely true. Rest CMP does not affect the heart rate, so this is false. CMP decreases the heart rate, this is also false. Okay, so whenever I am reading this decrease in heart rate, so only answer that is possible here, option number B. Very good. This is one of the important question which is going to be asked in future exams. So try to prepare this kind of question. Prepotential is a very important part in INI-CET or Central Institute exam, right? Okay. In patient presented with ST elevation in V1 and V2 lead, so this is basically you know from your medicine knowledge that this is very easier for you to answer. if you are getting ST elevation in beyond V2 leads, so obviously you are in diagnostic case of the myocardial infarction. But here the which wall is infracted. So in my ECG lecture I have told you that if there is infarction in beyond V2, this is basically septal lead, anteroseptal lead, okay, anteroseptal infraction. If there is V3 V4 elevation, ST elevation in V3 V4 lead, then that is the anterior myocardial infarction, and lateral V5 V6, and if there is 2-3 AVF, then that is the inferior wall myocardial infarction. And from your septal or anteroseptal, you can say septal is the answer. Now the septal means which artery is going to supply here, that is also it's very easy for you to remember. So septal wall infraction is the answer of this question due to left anterior descending artery occlusion. So the different arterial distribution where they supply, I believe you know better than me from your anatomical knowledge. So here the answer, looking at this V1 V2 lead, I can easily answer this is the septal oval myocardial infraction, septal infraction, okay, anteroseptal or septal, okay. Chalo. Next is in the His-Bundling electrogram. Again, this is a question which is important for INI-CET or okay, Central Institute exam rather than NEET PG. So His-Bundle electrogram is how it is recorded. All of you know that if this is the right atrium, left atrium, and this is the ventricle, so we placed our lead just beside this AV node. So if this is my AV node, we generally place the lead just beside this AV node. So this is for the recording of the His-Bundle electrogram, okay. So in His-Bundle electrogram, whenever you are placing the lead just close to the AV node, okay, so try to understand, suppose this is the SA node. So from the SA node, the impulse will travel down towards the AV node, okay. So this is the AV node. So whenever it is striking the AV node for the first time, first activation of the AV node will produce a wave which is known as the A wave in the His-Bundle electrogram, okay. Then when the impulses is going through this AV node, okay, and then after the AV node, which part of the conducting system is there? We all know that after this there is a His-Bundle electrogram is there, His-Bundle is there. So whenever this impulses is going through the AV node and then reaching at the level of the His-Bundle, then it will produce a H wave. So then this is produce a H wave. And then when the impulse is further going through this His-Bundle, then what is going to happen? We all know that ultimately it is going to activate the ventricular septum. So this is the septum of the ventricle, means the ventricular depolarization will start. So here again you are going to get another electrical activity or wave, that is a V wave in His-Bundle electrogram. So this 3 wave recovering, this is basically HBE, His-Bundle electrogram, right, His-Bundle electrogram. So basically in His-Bundle electrogram we are finding out the A wave, that is the depolarization of the AV node, then I am getting the H wave, that is the His-Bundle activation, okay, and then I am getting the V wave. So V wave is the ventricular depolarization static. So if you look at this diagram very closely, then you will be able to understand that whenever the V wave is starting, that is the point where in normal ECG QRS complex is also starting, QRS complex is also starting, because that also indicate ventricular depolarization, okay. So that's why it is matching these two things, okay. Now here you have to remember that there are certain interval, okay. So whenever the depolarization is starting from the SA node, whenever the depolarization is starting from the SA node, we know that in normal ECG, that is not the finding of the His-Bundle electrogram, but in normal ECG, which wave is going to be produced? P wave in the ECG is going to be produced. So from this P wave up to the level of A wave generation, this is known as PA interval, PA interval. This is 30 millisecond. So PA interval is 30 millisecond. Okay. Then the A wave will be produced and then H wave. So this is known as the AH interval. AH interval generally 100 millisecond. So this is the largest interval that you have to remember. This is 100 millisecond, right? And then HV interval. So this is HV interval. Okay. HV interval is normally 40 millisecond. I believe all of you remember, okay. So 3 interval you have to remember. One is PA interval, which is 30, okay. Then AH interval, that is the AV nodal delay, okay. So 100 milliseconds. So this is AV nodal delay also. So this is also known as the AV nodal delay. And then your HV interval, HV interval is 40 millisecond. If you add all of this, this is basically your PR interval in normal ECG. This is your PR interval. Combination of all these 3 is PR interval in normal ECG. Everybody tell me whether you got it or not. Okay, if you add all of this is nothing but your PR interval. What is PR interval? You all know that from the beginning of the P wave up to the generation of the QRS complex. QRS complex generation means that is also generation of the V wave. So ventricular depolarization. So this time interval is known as the PR interval. Now tell me everybody. Thank you so much. Now next, during a cardiac examination, okay, now this question, two answer is possible. I told you that whenever you are dealing with the first heart sound appear R wave, peak or later half of R wave, and second heart sound is generally end of T wave. Okay, end of T wave means if the U wave is present, then also it is going to appear, okay, during that time, end of T wave. So iska answer, this is also answer, this is also answer, okay. But if you have to answer only one, then end of T wave is a better answer. So I'll go with this D and C both, but D is better choice than C in this question. Okay, because U wave is not always present. U wave is very rare phenomenon in normal cases, right? So if the U wave is present, then also U wave is also can be an answer is to coincide with the onset of the U wave, that is also there. But better is end of T wave is the answer of this question, right? Okay. Next, which physiological mechanism best describes the Frank-Starling law? So what is Frank-Starling law? This is important to remember the mechanism. So Frank-Starling law, I told you that if there is increase in length of myocardium, then what will happen? There will be increase in contractility of myocardium. Okay, this is my basically Frank-Starling law. Okay, along with that, I also told you that if there is increase in heart rate, then also the contractility can increase. Okay, this is known as the Bowditch phenomena. Okay, this is known as the Bowditch phenomena. And the third one, increase in afterload can also increase the contractility. Okay, so all of them are positive. Okay, this is known as ANREP effect. Okay, so Bowditch effect, or this is ANREP effect. So all these three you have to remember. Okay, now here the question is why there is increase in length of the myocardium is increasing the contractility. This is due to length tension relationship. If you stretch the myocardium more actin myosin cross bridge will be there. Because of the more actin myosin cross bridge, the more contraction is going to happen. So here the question is which of the following mechanism best describe Frank-Starling law? So we have to look at increase in contractility. So if there is increase in contractility, what is going to happen? There will be increase in force of contraction. That means there will be increase in stroke volume, there will be increase in cardiac output. Okay, so here we are stopping here that increase contractility, but ultimately if there is increase in contractility, stroke volume will increase, the cardiac output will also increase. So please remember, the Frank-Starling law can also be described that in terms of cardiac output increment or stroke volume increment. Okay, so you have to be cautious. So here heart stroke volume decreases. So whenever I am looking at decreases, this is not my heart stroke volume regulated primarily by sympathetic nervous system. This is not my Frank-Starling law. Heart stroke volume increases, yes, in response to increase in end diastolic volume. So increase in end diastolic volume means that is going to increase the length of the myocardium. So option number C is correct. That is my answer. So this is true. The heart stroke volume remain unchanged. So whenever I am looking at unchanged, this is not my answer. This is not true. So this is very easy. Now if you remember this, that whenever there is increase in length of myocardium, contractility increases. Length of myocardium क्यों increase होगा? If there is increase in end diastolic volume, and end diastolic volume is also known as preload. So increase preload increases contractility. That is also true. That is Frank-Starling law. So increase preload increases contractility, Frank-Starling law. Increase afterload increases contractility. That is my ANREP effect. And Bowditch phenomena is increase in heart rate can also increase the contractility of the heart. That is Bowditch phenomena. Never forget these three effects. Very important for INI-CET. Now this is a very simple question from your first year knowledge or maybe your pathology knowledge. Everywhere this is taught generally. So in first year You remember that you used to do the blood grouping examination. So blood grouping chart slide ले लेते हैं हम लोग, एंड स्लाइड के ऊपर एक एक ड्रॉप ब्लड अलॉन्ग विद द सलाइन मिक्स अप करके उसके बाद एंटीसेरा डाल देते हैं, एंटीसेरा ए, एंटीसेरा बी एंड एंटीसेरा डी. सो इफ द एंटीसेरा डी इज पॉजिटिव मीन्स एग्लूटिनेशन इज फाइन. सो एग्लूटिनेशन ऐसे क्या होगा, आपको क्लॉटिंग जैसे ऐसे लगेगा, बट दैट इज नॉट क्लॉट, दैट इज नोन एज एग्लूटिनेशन. सो इफ यू आर गेटिंग दिस काइंड ऑफ क्लम्पिंग ऑफ द आरबीसी, दैट इज नोन एज एग्लूटिनेशन. एग्लूटिनेशन मीन्स दैट इज अ पॉजिटिव रिएक्शन. सो एंटीसेरा ए में पॉजिटिव मीन्स, ओके, एंटीसेरा ए में पॉजिटिव मीन्स ए एंटीजन तो होगा ही होगा, ए एंटीजन इज प्रेजेंट इन द ब्लड, एंटीजन इज प्रेजेंट इन द ब्लड. एंटीसेरा बी में भी मेरे को ये क्लम्पिंग दिख रहा है, छोटा छोटा ये जो क्लम्पिंग. सो क्लम्पिंग जब भी दिख रहा है तो मीन्स बी एंटीजन इज ऑल्सो प्रेजेंट इन द ब्लड. सो ए बी एंटीजन बोथ व्हेनेवर इट इज प्रेजेंट, सो ए बी ब्लड ग्रुप मेरे को आ गया. सो ए बी ब्लड ग्रुप तो है ही है. उसके बाद हम लोग देखते हैं कि वेदर द इट इज़ ऑल्सो पॉजिटिव इन एंटीसेरा डी और नो. इफ द एंटीसेरा डी में भी ऑल्सो पॉजिटिव आपको मिल रहा है तो दिस इज बेसिकली आर एच पॉजिटिव, दिस इज बेसिकली आर एच पॉजिटिव. सो हम बोलते हैं कि दिस इज बेसिकली माई ए बी पॉजिटिव ब्लड ग्रुप. इफ इट इज़ ओनली पॉजिटिव इन ए तो ए ब्लड ग्रुप, ओके. इफ इट इज़ ओनली पॉजिटिव इन बी, बी ब्लड ग्रुप. इफ बोथ आर नेगेटिव so that is O blood group, that all of you know. So because here both are positive, so this is AB. If both are negative, so this is O. And depending on this antisera D, positive or negative, AB positive बोलेंगे कि AB negative बोलेंगे, that depends whether this antisera D is positive or not. If it is negative, तो negative blood group. AB and ABO मतलब ABO blood group is depending on this antisera A and antisera B. I believe all of you know that. Easily you can आंसर दिस क्वेश्चन. ठीक है, ये दे सकते हैं. अभी भी ऐसे टाइप का क्वेश्चन नहीं दिया, बट एक बार क्वेश्चन दिया था वो जो न्यूबर्स चेम्बर होता है ना, न्यूबर्स चेम्बर जो आप कैलकुलेट करते हो, दैट न्यूबर्स चेम्बर उस क्वेश्चन वाज गिवन इन वंस INI सेट क्वेश्चन. ओके, सो दिस काइंड ऑफ क्वेश्चन कैन आल्सो बी गिवन इन फ्यूचर. ओके, नाउ इन दिस क्वेश्चन 20 इसमें थोड़ा सा गलत है, मतलब इधर यू हैव टू चेंज दिस ऑप्शन C and D, otherwise you have to change on your right hand side, otherwise this is not correct. Why it is not correct, I'll tell you. So counter current system आप देखोगे तो काउंटर करंट सिस्टम में मैंने आपको बोला था कि देयर शुड बी टू पैरेलल ट्यूब. सो दिस इज द डिसेंडिंग लिम्ब ऑफ लूप ऑफ हेनले and this is the ascending limb of loop of Henle and this is the medullary collecting duct. Okay, medullary collecting duct. All these three tubes are parallel to one another. This is one, this is one, this is one. All three are parallel to each other. And if you look at the flow of urine, so flow of urine is downward, upward and again downward. So flow is also opposite direction. So it is following the counter current rule. Okay. Now in this counter current rule, if you look at the medullary tonicity, so medullary tonicity देखो, here it is 300, so this is towards the cortex of the kidney, and then whenever you are going deep towards the medulla, what you are finding out? You are finding out that the tonicity is rising. Why the tonicity is rising? Because of the presence of this urea, because of the presence of this sodium chloride. These are the two substances which increases the medullary tonicity. So what is the most important two substances? Urea and sodium chloride. But urea, which is generating medullary tonicity, where from it is coming? Urea is coming from the medullary collecting duct, and sodium chloride, where from? This is reabsorbed. This is reabsorbed from the ascending limb of okay, loop of Henle. Okay, because we know descending limb of loop of Henle में sodium chloride, there is no solute reabsorption. So ascending limb of loop of Henle is generating medullary tonicity plus urea, which is reabsorbed from the medullary collecting duct, that is also generating medullary tonicity. But now suppose you have reabsorbed urea in the interstitium. So this urea is going to enter. So this is urea and sodium chloride. This solute is going to enter in the descending limb of the vasa recta. So vasa recta, this is basically blood vessels. This is peritubular capillary loop. This is basically blood vessels, right? So whenever the blood is going towards the tip of the medulla, okay, so this is the direction of the blood. So blood will try to reabsorb this solute from the interstitium. So that's why solute is entering. This is a diagram from Guyton's. So you can find out solute is entering in the descending limb of the vasa recta. Okay, and what water is coming out? Water is coming out. Water is coming out. So descending limb of vasa recta, solute will enter and water will come out. In the ascending limb, the solute which has entered in the vasa recta, that is again reabsorbed. That is again reabsorbed. That is taken out from the blood in the medullary interstitium, and in turn, what is going to happen? Water is entering in the ascending limb of vasa recta. So if you look at the description here, first we look at here, ascending limb of loop of Henle. What is the function of ascending limb of loop of Henle? They reabsorb sodium chloride. Okay, so that actively transport sodium and chloride into the interstitium. Absolutely correct statement. So this is, so A is matching with, I am matching this, A is matching with C. Perfect. Okay. Second, descending limb of loop of Henle. Descending limb of loop of Henle, I told you that is impermeable to solute, only permeable to water. So this descending limb of loop of Henle is matching with D. Okay. So A with 1 with C, 1 is matching with C. So either my B and C is answer. Then 2 is matching with D. So this is going to be my answer. B is going to be my answer. Okay. But if you try to match the other two, 3B and 4A, एक बार देख लो 3B के साथ मैच हो रहा है ascending भाषा रेक्टा. Ascending भाषा रेक्टा क्या करता है? Solute को, okay, blood gain water and loses solute as it passes through the less concentrated interstitium. Okay, so देखो ascending भाषा रेक्टा, यहाँ पे देखो ascending भाषा रेक्टा, so blood is losing solute and it is getting water. So what it is gaining, ठीक है? So matching, okay, blood gain water and loses solute as it passes through the less concentrated interstitium. So ये जो less concentrated interstitium ना, इसको थोड़ा सा इस जगह पे थोड़ा सा करेक्ट होना चाहिए. As it passes from the concentrated towards the less concentrated interstitium, ऐसे होना चाहिए था. As it is passing through the less concentrated interstitium means it is not the less concentrated, it is going from the higher to the lower concentration. So here is a little bit correction required था. Otherwise ठीक है. Descending limb of भाषा रेक्टा, descending limb of भाषा रेक्टा में क्या होगा? The solute is entering means blood is gaining solute and losing water. Blood loses water and gains solute. So this is going to matched here. ठीक है. So this part is only a little bit correction was required. Otherwise बाकी option match कर रहा है. So answer is going to be the B here. ठीक है. So this is a little bit difficult because when I was reading for the first time मेरे को लग रहा था ये दोनों पूरा गलत है. Okay. अब देखो पूरा गलत नहीं है, थोड़ा सा गलत है कि एक है कि लो टू हाई सॉल्यूट डायरेक्शन में जा रहा है और एक होता है हाइपर टू लो सॉल्यूट डायरेक्शन में जा रहा है. असेंडिंग एंड डिसेंडिंग लिम्ब ऑफ भाषा रेक्टा, ये दोनों को करेक्ट करके आपको सीखना होगा. ओके, सो प्लीज़ रिमेंबर दैट काउंटर करंट सिस्टम मीन्स ये जो भाषा रेक्टा है इसको हम लोग क्या बोलते हैं? भाषा रेक्टा को हम लोग बोलते हैं काउंटर करंट एक्सचेंजर सिस्टम. दिस इज द काउंटर करंट एक्सचेंजर सिस्टम एंड इसको हम लोग बोलते हैं काउंटर करंट मल्टीप्लायर सिस्टम. काउंटर करंट मल्टीप्लायर सिस्टम. सो काउंटर करंट मल्टीप्लायर एंड काउंटर करंट एक्सचेंजर दोनों कैसे काम कर रहा है इस जगह से आपको क्लियर होना चाहिए. ठीक है, डिफिकल्ट था. ओके, नाउ और एक क्वेश्चन है, उस टाइम में फिर से ये क्वेश्चन आएगा कि यूरिया एंड सोडियम क्लोराइड लेके क्वेश्चन है. और ओके, अब इससे पहले देखो व्हाई इन्यूलिन क्लियरेंस इज द गोल्ड स्टैंडर्ड. दिस वी आर नॉट गोइंग टू डिस्कस बिकॉज ऑल ऑफ यू नो दैट इन्यूलिन इज अ फ्रीली फिल्टर्ड, neither reabsorbed nor secreted ideal substances. So whenever it is freely filtered and neither reabsorbed neither secreted, so that is basically give you the clearance. That clearance will give you the GFR. So this B is the answer. So B is the going to be the answer in this question. Okay, उसके बाद 63-year-old man complain of increased micturition, tingling, numbness and non-healing fasting blood glucose is. Okay, so here we all know that if this is the Bowman's capsule, so there will be filtration of glucose. After the filtration of glucose, suppose there is filtration of glucose, we all know that 100% glucose is reabsorbed. 100% glucose reabsorption will happen because of the presence of SGLT2 and SGLT1. But you know कि whenever this amount of glucose is more than that of the threshold, of reabsorption, that threshold is known as the renal threshold of glucose, RT of glucose. So that exceeds, whenever the glucose is exceeding the renal threshold of glucose, then it is going to appear in the urine. So the simple answer is exceed the renal threshold. Next is, which transport mechanism is primarily responsible for bicarbonate in the proximal convoluted tubule? So this is a very interesting mechanism. I have discussed mainly in my main video lecture, not in RR. So suppose this is the proximal tubule and this is the epithelium cells. This is the epithelium cell, this is the lumen of the proximal tubule. So in the proximal tubule, I believe all of you know that there is an important transporter which basically reabsorbs sodium ion, but that reabsorption of the sodium ion happens in exchange of H plus secretion. Yes, H plus secretion. And what is the name of this transporter? This is known as NHE, sodium hydrogen exchanger. Then what happens, this H plus ion which is secreted here, it is going to react with the bicarbonate in presence of carbonic anhydrase. So carbonic anhydrase reaction karega, it will convert it into H2CO3. This H2CO3 will be divided into water and carbon dioxide. Now this carbon dioxide will be entering in the cells, and then again inside the cell it is going to react with the water, and again it will form the carbonic acid. Now this carbonic acid will be again divided into bicarbonate, okay, H2CO3. This will be again divided into bicarbonate ion. Now this bicarbonate ion will be reabsorbed in the blood with the help of sodium bicarbonate cotransporter, sodium bicarbonate cotransporter, NBC, sodium bicarbonate cotransporter. So basically in the basolateral membrane, the transporter is sodium bicarbonate cotransporter, but in luminal membrane there is no such transporter for bicarbonate itself, because there is no one to reabsorb the bicarbonate directly. But how this bicarbonate is reabsorbed? By a reaction, chain of reaction. The same reaction is happening inside the lumen also, inside the cell also. But this reaction will happen only and only if the H plus ion is secreted. So this H plus ion secretion is one of the main step in bicarbonate reabsorption in proximal tubule, and that's why answer is NHE, sodium hydrogen exchanger or antiporter, NHE transporter. Okay, this is the answer. Now which of the following substances plays a crucial role? Okay, so this was we were discussing. So hyperosmotic medullary interstitium means this is basically generation of medullary tonicity, by countercurrent multiplier system, So basically this is a question related to countercurrent multiplier. So we know that sodium chloride is also required plus urea is also required. Just now we have discussed sodium chloride combination is responsible for 60% tonicity, urea is responsible for 40%. But here the sodium chloride is given into sodium and chloride alag. So sodium is responsible for 30% of the total tonicity, chloride alone is responsible for 30% another tonicity, urea is responsible for 40% tonicity. Potassium is not responsible for medullary tonicity because it is diffused back into the lumen of the nephron. So that's why if I have to choose the single most important substances for this question which is responsible for medullary tonicity, then urea is the answer. Otherwise sodium chloride is a better answer, but here sodium and chloride has been given as a separate choices. So sodium is different, chloride is different, they are 30% contribution, maximum contribution based by urea. Okay, next. In nitrogen washout method, so this nitrogen washout method is the method which is used to calculate the anatomical dead space, okay, dead space. Along with that, this method is also used to measure the closing volume of lung. Okay, single breath nitrogen washout method. Multiple breath nitrogen washout method is used for calculation of the residual volume, that you also know. Nitrogen washout method, if I say without single breath, multiple breath kuch nahi bola, so nitrogen washout method can also be used for residual volume measurement. But whenever this graph is given, this is basically single breath nitrogen washout method. This is known as the single breath nitrogen washout method. What is done? Nitrogen is calculated in this single breath. So dekho ye jo phase 1, so the phase 1 is the representation of the dead space. Which kind of dead space? This is anatomical dead space, okay. So I told you that this method is used to anatomical dead space measurement. So phase 1 means the first flat portion, this flat portion is phase 1, this is anatomical dead space, first portion. Then we are finding out that there is a phase which is phase number 2, where the graph is moving in the upward direction, means nitrogen is more. So this phase 2 is basically a mixture of dead space, DS, and alveolar gas. Okay, you have to remember this. Okay, then you are getting a phase number 3, this flat portion, this is phase number 3. Phase number 3 means this is basically, okay, so phase number 3 is basically pure alveolar gas, okay, pure alveolar gas. And then the transition from this, what is important here? The transition from phase 3 to phase 4, this is basically my closing volume. So this is closing volume, and after closing volume, the phase number 4 which you are getting, that is nothing but your residual volume. So this is the volume which you are calculating, this is the volume which is residual volume. Okay. So this graph has 4 phase, right? So if I ask you what is this phase number 1, that is the anatomical dead space volume. If you measure this volume, this is anatomical dead space. Then there is a mixture of dead space plus alveolar. This phase has not much importance. Then this phase is the pure alveolar gas, means this is the air which is coming from the alveolar region only, pure. And then whenever you are reaching this point, if you measure the volume here, this is the your closing volume, and after closing volume, the volume which you are getting, this is basically your residual volume. So question here that curve में जो phase 3 है, so what is the representation of this phase 3? So phase 3 is basically the pure alveolar air coming from the alveolar region. Option number C is the answer. Okay. So phase number 3 they are asking, phase number 3 is pure alveolar air. This is the question they are asking. If they are asking transition from phase 3 to phase 4, the closing volume, only phase 4, that is the residual volume. At least you remember this, and phase 1 means that is anatomical dead space.